Today I am going to discuss about a topic cytomegalovirus. Let us look into the topic. Cytomegalovirus is known as salivary gland viruses. It is the largest virus in the Herpes virus family. In neonates and immunodeficient, it causes severe disseminated disease, whereas in normal children and adults, infection is usually asymptomatic or self-limited. The characteristic feature of cytomegalovirus is enlargement of infected cells and prominent intranuclear inclusions is seen. Antigenic structure. CMV is unrelated antigenically to other herpes virus and even CMV of other species. But the exception is for simian CMV, antigenic cross reaction exists. Now let us look into the epidemiology. Generally, cytomegalovirus spreads slowly and probably requires close contact for the transmission. It may spread through sexual contact, blood transfusion, and organ transplantation. Viruses has been detected in saliva, urine, cervical secretions, semen, blood, and milk. Congenital infected infants have viruria for up to 4 to 5 years. Now let us see the clinical features. Clinical features are basically divided into three infections: congenital infection, infection in infants, and infection in children. Now let us see the first infection, congenital infection. So here, intrauterine infection leads to fetal death or cytomegalic inclusion disease, which is often fatal. This is a generalized infection associated with hepatosplenomegaly, jaundice, thrombocytopenic purpura, and hemolytic anemia. Now let us see the congenital manifestations of cytomegalovirus. There are four manifestations. First one is microcephaly, choriorhinitis, cerebral calcification, and congenital toxoplasmosis. The most important cause is microcephaly. Now let us see the second infection, infection in infants. Cytomegalic inclusion disease is seen almost exclusively in infants born to mothers who develop primary CMV infection during pregnancy. Infants of mother who have CMV reactivation during pregnancy tend to have chronic subclinical infection. Perinatal infection may be acquired from the infected mother through genital secretions or breast milk. Now let us see the third type of infection, that is infection in children. Here, primary infection in older children and adults are asymptomatic, but in immunocompromised hosts such as an AIDS patient, CMV can cause severe fatal infections, and other immunocompromised states such as organ transplant patients and autoimmune diseases. Infection mononucleosis is seen in the adults when transfusion of CMV infected blood is done, and it leads to post-transfusion mononucleosis. Now let us see about the lab diagnosis. Lab diagnosis: the specimen collected is urine, saliva, semen, and cervical secretions, and isolation is done in the human fibroblast cultures by inoculating them, and growth in cultures can be detected early by using shell vial cultures and by staining the cells with fluorescent tagged antibody to early antigens of CMV. A simpler but less reliable technique is the demonstration of cytomegalic cells in centrifugal deposits from urine or saliva, in which inclusion bodies are seen. So this appearance will be as owl's eye appearance. Owl's eye appearance is an important feature, and remember it. Now let us look into the prevention and treatment of the cytomegalovirus disease. First point is CMV immunoglobulins are employed in high-risk patients. High-risk patients are the persons who are immunocompromised, organ transplant patients, and the persons who are suffering with autoimmune diseases. Prophylaxis for cytomegalovirus is acyclovir, and treatment for cytomegalovirus is ganciclovir and foscarnet, and there is no vaccine available for cytomegalovirus, but the experimental vaccines such as Town 125 and AD 169 strains and the purified CMV polypeptide vaccine has been found to be immunogenic but not effective in protecting immunodeficient subjects from CMV infection. Thanks for watching. Do like, share and subscribe the channel. Thank you so much.